Evidence-based medicine has made progress since doctors' infamous bloodletting of George Washington, but less than you might think. Why do doctors still offer treatments that may not be helpful? That's the topic of this week's Healthcare Triage. Special thanks to Austin Frack, from whose Upshot column this episode was adapted. When your doctor gives you health advice and your insurer pays for the recommended treatment, you probably presume it's based on solid evidence. But a great deal of clinical practice that's covered by private insurers and public programs isn't. The British Medical Journal sifted through the evidence for thousands of medical treatments to assess which are beneficial and which aren't. According to the analysis, there's evidence of some benefit for just over 40% of them. Only 3% are ineffective or harmful. A further 6% are unlikely to be helpful. But a whopping 50% are of unknown effectiveness. We just haven't done the study. Sometimes uncertain and experimental treatments are warranted. Patients may even welcome them. When there is no known cure for a fatal or severely debilitating health condition, trying something uncertain as evidence is gathered is a reasonable approach, provided the patient is informed and consents. The gathered evidence should then be analyzed so we know what works and what doesn't in the future. In many cases, routinely delivered treatments aren't rigorously tested for years. Benefits are assumed, harms ignored. This kind of thinking may have killed George Washington. At 67 years old and a few months shy of 3 years after his presidency, Washington reportedly awoke short of breath, with a sore throat, and soon developed a fever. Over the next 12 hours, doctors drained 40% of his blood, among other questionable treatments. Then he died. Washington surely had a serious disease. Theories include croup, diphtheria, pneumonia, and acute bacterial epiglottitis. Whatever it was, bloodletting did little but cause additional misery and most likely hastened his death. Though the procedure was common at the time for a variety of ailments, its benefits were based on theory, not rigorous evidence. In the era of modern medicine, this may strike some as primitive and ignorant. Hundreds of years later, the same thing still happens, though fortunately not with bloodletting. In the late 1970s, some doctors thought they'd found a way to treat breast cancer patients with what would otherwise be lethal doses of chemotherapy. The approach involved harvesting bone marrow stem cells from the patients before treatment and reintroducing them afterward. Fueled by encouraging comments from doctors, the 1980s news media reported higher chemotherapy doses as the means to survival. Yet there was no compelling evidence that bone marrow transplants protected patients. But, told they would, many patients fought insurers in court to get them. Under pressure from Congress in 1994, all health plans for federal workers were required to cover the treatment. Yet not a single randomized trial had been done. Finally, in 1995, the first randomized trial was published with impressive results. Half of women who received bone marrow transplants had no subsequent evidence of a tumor, compared with just 4% of the control group. But these results didn't hold up. With 4 subsequent clinical trials contradicting them, the approach was recognized for what it was: ineffective at best, lethal at worst. Wishful thinking that runs ahead of or goes against research finding is behind today's opioid epidemic too. Despite a lack of solid evidence, for years many believed that modern opioid medications were not addictive. It's now abundantly clear they are, but the damage is done. There are countless other examples of common treatments and medical advice provided without good evidence. Magnesium supplements for leg cramps, oxygen therapy for acute myocardial infarction, IV saline for certain kidney disease patients, the avoidance of peanuts to prevent allergies in children, many knee and spine operations, tight blood sugar control in critically ill patients, clear liquid diets before colonoscopies, bed rest to prevent preterm birth, and the prescribing of unnecessary medications, to list just a few. In some of these cases, there's even evidence of harm. It is not uncommon for newer evidence to contradict what has been standard practice. A study examined 363 articles in the New England Journal of Medicine, starting from 2001 to 2010, that addressed an existing medical practice. 40% of the articles found the existing practice to be ineffective or harmful. Some of these reversals are well known. For example, 3 articles contradicted hormone replacement therapy for postmenopausal women. Another 3 reported increased risk of heart attacks and strokes from the painkiller Vioxx. Looked at one way, medical reversals like these represent a failure. We didn't gather enough evidence before a practice became commonplace. But in another way, they were at least a partial success. Science eventually caught up with practice. That doesn't always happen. This is all part of a growing movement to identify harmful and wasteful care and purge it from healthcare systems. The American Board of Internal Medicine's Choosing Wisely campaign identifies 5 practices in each of dozens of clinical specialties that lack evidence, cause harm, or for which better approaches exist. The organization that assessed the value of treatments in England has identified more than 800 practices that officials there feel should not be delivered. It's an uphill battle. Even when we learn something doesn't make us better, it's hard to get the system to stop doing it. It takes years or even decades to reverse medical convention. Some practitioners cling to weak evidence of effectiveness even when strong evidence of lack of effectiveness exists. This is not unique to clinical medicine. It exists in health policy too. Much of what we do lacks evidence, and even when evidence mounts that a policy is ineffective, our political system often caters to invested stakeholders who benefit from it. An honest assessment of the state of science behind clinical practice and health policy is humbling. Though many things we do and pay for are effective, there's a lot we don't know. That's inevitable. What isn't inevitable, and where the real problems lie, is assuming without evidence that something works. Hey, did you enjoy this episode? You might enjoy this other episode where we focus on how hard it is to get doctors to stop doing stuff once they've started. We'd also like to start getting you to support the show at patreon.com/healthcaretriage, where, like our research associate Joe Sevitz or our Surgeon Admiral Sam, you can support the show and help us make it better.